Okay, welcome back, everybody. We are going to just get started and keep things underway. We're going to go into our rapid fire sessions now. We have two sessions next. We're going to look at mobility, and then we're going to move into sleep. So I have the pleasure of welcoming William Tung. William is a physiotherapist from the Royal Alec. And he is part of the Adult Delirium Steering Committee. And Heather Colaco, who many of you know, as she is one of the practice leads for the Provincial Delirium. Take it away.
Thanks, sir.
Hey.
You gonna roam with me? Go ahead.
Sure. Shall I use one just like this? Oh. Well, you don't want to get an Asian, get a mic, right? So I thought karaoke is on right now. 3 o'clock, right? Perfect time, tea time, right? Thanks to everyone. Thanks for the introduction. It's my pleasure in here and also my honor to present together with Heather because both of us actually got a passion in what we do in here, in mobilization. And it's great, it almost echoes what Dr. Elbridge and also Tracy mentioned about the mobilization. All the evidence is here. We got it to do it, and maybe we should just do it in here. So you got the clicker in here, right?
Do you want to roam with the mic?
Sure. Where's it? This one. All right. Ooh. First, you don't want to trip in here. All right. All right. Let's see what we have for the first line here. So, early and safe mobilization. Remember the safety as well, very important. We have nothing to disclose in here except our passion in doing early mobilization. We got to get people moving. It's helping for the delirium. It can help them to get back to the function and the baseline very quickly. All right. Why do we need to mobilize? There's so many evidence showing that we need to mobilize people to optimize all those kind of the function in them, and also like all the try to tackle all those like 1.3 to 3% of the muscle strain loss per day, and also all those range of motion. We know all this already. Why are we not doing it? Is there some other barrier or fear that we have that it cannot be done? However, we also need to look at, we have to work smart rather than just working hard in here. You have so much on your plates already, but we can work together. You may have 1 or 1.5 physio, either the top or the bottom half, to work on your unit. Like on our units, we got about 28 beds. We only got 1.5 physio. So how much can we do and work smart in here? Try to get working together with what you need to do the other things. Maybe getting the patient up to the bathroom. Okay, maybe getting them set up by the bedside so we can wash their back, change the linen as well. Or I learned how to lots of things from Heather and also some of my buddies over at the MIS, at the Royal Alex as well. I know how to turn the patient, put the soaker on, help to clean the bottoms as well, and then put, I don't know what kind of cream that you put on. Like, that was amazing. So they all turn white at the first, and then, and then will become yellow again, like me. All right. But this is also it's a teaching moment as well. They taught me how to do things about all the lines and tubes, and you have to either use 40 mils or 60 mils of water after you stop the tube feeding. Otherwise, it will plug up, and guess what? Gee, William, I have to put the tube in again. At the same time, I also share my knowledge as well, how to use certain kind of equipment as well. Arjo walker, whatever walker, jolly jumper, I mean the walking sling, it's actually worked quite well. And also some of the other equipment as well. And this is before. I took this picture from the internet, probably before 1970. Well, they have the rocky view that they can see outside there. But right now, this is actually what is always new again. Not really. We have to exercise. Who are the PTs in this room? At least I know 2 or 3. Oh, awesome. We are the movement specialists, right? Sometimes we will say we don't have enough time to do exercise. We cannot afford the time to do exercise like our patient. My wife said, William, you cannot afford not to do exercise. Look at your muffin top, it's hanging down right here. My belt is getting from 32 to 36, and it's not very good. That was before, and now look at what do we have right now in here. That may be just, I got a picture from your unit. Does it look right? It's just like every day we work nowadays. On the left middle picture, that was my mom. when she had her craniotomy done, almost like 2 years ago. She got a 6 centimeters meningioma in her frontal lobe. They took it out, great Dr. Wheatley, and actually helped her a lot. And then we actually helped her to get up. That was the day 2 or day 3 after her surgery. And the nurses, when I asked them, can I get my mom set up at the bedside? Guess what they said? Sure, I can help. Sure, let's do it. And that's how we did it. Thank you, the U of A Neuro ICU. Carry on to the next one. And mobility is part of the bundle. And I really enjoyed the talk that Dr. Ulrich kind of mentioned in here. But we look at that as a bundle. I talked to Heather about this slide. When I think about the bundle, it's like a bundle of bouquets of flowers. I look at the whole bundle of flowers when I present it to my wife, even though she's allergic to flowers. But and then not looking at just one kind of roses in there, or one rose in there, or the carnation. But we have to look at everything together. And the research, the latest one of them is actually this year showing that delirium and also any lines and tubes can be a hinder. But it's not. We actually get people up moving, just like the last slide. Okay, carry on. Why should we mobilize our people? All the benefits, maintain the functional mobility, the independence, the endurance, get them moving, sitting up as well. Some people ask me, why did we keep the patient in a bed chair position? Is it helping the mobility? Maybe helping the delirium. They're more upright, they can see a bit further. They may not see the outside, there's no window, but if you're living in San Francisco, you can see all the park, a nice place as well. How?
Does your hospital have windows for your ICU?
We do. Some are more luxurious than others. Some have
Oh,
a fridge and some have
Wow.
yeah. Some of my, yeah. The Royal Alex ICU used it to have, well, we still got lots of windows. And then guess what we do? We build more buildings surrounding it. So we can only see the outside part of it, but if we can, we still try to move some of the long-term patient to the size that they can see outside. You don't even know what is day and night. I mean, including nurses too. They don't even know what is the weather outside, right? Okay. And also it can help to improve the quality of life. Most of our patients coming in, they actually can be walking in and they got actually quite sick on the units and get transferred to ICU. We need to know about the baseline and we can help them back to where they are, to engage them, to get the family to help as well. Hopefully you can also help in all those E loss and A loss. Probably most of the managers have been gone through those length of stay kind of meeting. You got to transfer the patient. How can we mobilize? We can get people moving, right? Sitting up by the bedside, range of motion, exercise as well. I got a dumbbell for Heather in here, 3-pound weights in here, do the exercise. She can do it like continuously for the 6 minutes that I'm going to talk right now. Let's see how she's doing at the end. And you do that, right? We got a TheraBand. I love to use the TheraBand, make it as a slingshot when the doctor comes doing the rounds. Sorry. And it's actually, you can see the giggles of the patient. If you get tired, you should put it down too. Pass it around, try it, the 3-pound weight. And you can get patients standing, marching on the spot. If the patient was a ballroom dancer, I'm not. And then you can actually get them start dancing as well, shifting weights, may as well do the 2-step, and well, Asian dancing, this is not that good. Okay. And then you want to make things about meaningful to your patient. I got a patient, I remember that she couldn't even lift the arms up, okay, to do the active range of motion. Guess what I give her? One of the eyeshadow. She can do it all in here. Why would that happen? Because they still got the motor memory as well. Get something that meaningful for them to do. If you're really good at about your hair, I lost them all anyway, but you can also get them a hair dryer. Maybe they will actually dry their hair. Brush the teeth. Maybe this is something, get creative on that. And then you can get the patient walking either with the walking sling or using other different things to walk, maybe the archer walker. And then what is the fear about getting patient up? Because it takes time. You're so busy already. Instead of like, okay, every time I need to get a patient up, I have to find the bedside nurse, and then my assistant, and also the respiratory therapist. But when the patient getting moving better, maybe Cynthia can, one of our RT at the Royal Alex can work with Heather together to get the patient moving. Division of labor, work smart, one more time. Okay, and we all know all this. What are we going to do with all this kind of parameters in here? Heart rate, MAP, blood pressure, rhythm, everything. This is all relevant to our mobilization because when you exercise, there's a physiological changes. But when you look at all these parameters, I challenge you to think about any task that you have to do on the unit that you don't look at all this. Putting a KOF tube in, putting a central line in, what else? Changing dressing, measuring about the pain. You all need to look at that. Thank you. Okay, how frequent do we need to mobilize? I'm so happy that Tracy already mentioned 3 times a day, that's what we aim. And also Dr. Elrich mentioned about as frequent as you can. I remember one of our sites is saying that GS ICU that trying to mobilize people 6 times a day. Which hospital is that? Is it somewhere in the south? Okay, maybe in the province somewhere, okay. And I was like, wow, that's an aspiration goal in here. We can achieve it, and we try to get driven, make sure that we use different activities as well. Some of the other equipment that we have is the tilt table or the Movio XP. I'm so jealous to the U of A colleagues as well, the GS ICU. They have the nice Movio XP. Next one. Let me think again. Yes. All right. So we also need to understand our patient. We all have fear. Certain thing about the patient, they're all well, just like me and you. And I treated some young patient coming to ICU, they were so sick. They cannot talk, they got a tube in their mouth. We all come in with the mask and yellow gown. We come in and we go, so passive. They got fear. We need to watch out the psychological factor. From Nadine's her video saying that's about her mental, kind of the recovery take a long time. Take that into consideration. And this is one of the pictures that, thanks for giving us the permission to use it, so they will get out of the bed. Oh, right on, yes. What's he doing?
He's doing a crossword puzzle. He's mobilizing his brain.
Absolutely. And then the next one that we should try to teach them is how to write Chinese. So it's quite easy. Everybody can write Chinese. So I can write Ukrainian, Russian, and so on. And as a team, we have a team approach, not just me, not just Heather, everyone else. And the team in here is all the profession in here. But guess what? I miss one very significant members in here, our patient and also their family, because they are our focus in here. How can we get success in here? We have to get a common vision. What do we understand about the bundle in here? We need to work on kind of a criteria or guideline that will work for your units, because our population can be quite different as well. And we need to identify who may be the leaders. Sometimes Heather will be the leader because the patient she knows quite well. Sometimes I will be the leader because I use so funky kind of equipment, like a nunchuck or whatever for exercise. I use to hang up pillows tied up to the curtain rack so that the patient can do the punching. Until one time that I forgot, it's Kevin or whoever from the respiratory said that the pillow bounced back and hit the patient trick, make them cough. Yeah, that's helped kind of the clearance as well. You have to be creative on that. And there's no recipe. It's a guideline so you can challenge your patient. If I cannot do it now, what else can I do in the next shift or tomorrow? There's no failure. It's just something that you learn and other learning opportunities. I love National Treasure, the movie. Has anybody seen it? Do you remember Nicolas Cage mentioned? Thomas Edison spent about 1,000 times to make a light bulb. He finally got it. He did not fail 999 times. He found out 999 times that he cannot make a light bulb. Think about that. Okay. All right. The other key to success is we need to identify the barrier. What kind of barrier that we have? Is it in our mind that I'm not used to this kind of activities? Maybe I can start some simple things. Work from the simple and learn from each other. Don't feel bad to ask questions. Get the exercise meaningful. Get them to make some events and get the family involved as well. I love getting the patient sit up by the bedside. The first time I get them up, I ask the family to come by, give the patient a hug. I still got tears every time I see that, because that means so much for them. And for some other younger patient, how do you feel about the weights? Who got the weights right now? Nobody is gone. Oh, it's still here. Oh, the thing about this is I'm a hardcore Star Wars fan. Think about another 3-pound weight. This is my exerciser for one of my patients at the MIS when I was working there. He couldn't even lift his arms up for the 2 pounds weight. He was holding this and start fighting with me. So think about that, and I will pass this one around, but you may be doing a lot of noises. I give it to San Francisco representative first. All right, so now I pass the buck to Heather.
Thanks, William. That was great. So should we mobilize early? So why we should mobilize early, and should we mobilize early? A nursing perspective, and we've talked about this morning, and how this is an interdisciplinary approach, and it's not just William's responsibility, and it's not just my responsibility. We have to do it together. Look at that little girl's face. This picture came from Salvi, from a patient she looked after in the CVICU as part of the, I think it was part of the, pardon me? The pediatric stollery. Obviously, she's not an adult patient. I should have realized that. But what resonated with me is her face. Look at her face. She's sitting on foam mats on the floor. Do we ever put our patients on the floor on purpose? We had a patient once at the ALEC, I remember, quite delirious, trying to get out of his room. You know what the nurses did because he couldn't stay in bed? They actually put blankets on the floor. They actually took pillows and made him a safe area. So if he's not going to stay in bed, why do we have to keep him in bed? Let's get him out of bed. He wasn't intubated. He was able to walk around. But they actually gave him a safe place where he could play, to lack of a better word, so he could actually mobilize and do it in a way that we don't necessarily think of all the time. We always think that our events have to be around the bed or be around equipment that we use. So the way I think about mobility is mobility assessment is a nursing assessment. So I do a musculoskeletal assessment on my patient. I don't chart it in Medivision per se because the charting in Medivision doesn't really support what I want to communicate during rounds. It's part of our general nursing care. So if you look at nurses on the wards, I love our Foley catheters, the one-point restraints. As someone mentioned, I think it was a clinical ground rounds last month. One of the physicians referred to it that way. How many patients do we leave Foley catheters in that we need to monitor continuous ins and outs every hour that perhaps don't need to have continuous in and out monitoring? The one-point restraint, if your patient has to go to the bathroom, try to keep them in bed if they have to get out. Facilitating and coordinating nursing care. So as William talked about with supervision, I think one thing that we want instant results. We want our patients we titrate a medication, we see an instant result. We want to turn our patients, so we turn them for them. We don't allow them an opportunity to engage in activities like that. So participating in their care and supporting them in that care is very important as well. We talked about bed rest complications. Yes, people still get bed sores. I don't know how it happens in ICU, but it does happen. Sharing the tasks. So we talk about sharing roles and responsibilities. There are some units that have utilized nursing attendants that were hired to do basic bed baths and basic bed care. They can participate in mobility. Let's look at the people that we have in our unit and think about using their role in a different way. And what suggestions can we do as nurses to promote mobility? One thing that I think of that jumps out of here, sleep and nutrition. How many patients do you see that get admitted to a unit that get fed within the first 24 hours? Can I see a raise of hands? I see a lot of patients that we delay, and that's I think one thing units are working towards is starting nutrition and feeding early. So we talk about early mobility, but we don't maximize that patient's functional capacity to actually do that. We keep them sedated, we keep them in bed, we don't feed them, we don't let them sleep. So these are all things that we can bring up during rounds in our communication to help facilitate and maximize our patients' return to their quality of life. So know your role. This chart may be, I apologize, chart may be hard to see at the back of the room, but this is something that I came up with as I kind of stole this idea from a presentation that I saw at Dynamics last fall. And one of the girls from the St. Mary's unit actually created a chart like this, but with roles and responsibilities in respect to delirium care in the bundle. So I thought, why can't we make a roles and responsibility chart in respect to mobility? Some of the roles and responsibilities go across disciplines, building awareness within your team. It's not just on your physician. It's not just on your nurse or your physiotherapist. So William is not just solely responsible for mobilization. I highlighted a couple of these from the physician, nurse practitioner, or physician assistant side. The bundle. So let's talk about our communication about the bundle. Are we treating pain? Is there a pain plan? One thing that I always think about, and when we get a patient up for the first time, and I think this came up in the curbside consultation pain session, is treating pain before we mobilize. So we're getting patients up, and then 5 minutes into their, I love the word dangle. When I say I'm going to dangle you at the bedside, patients always cringe. So when you sit a patient up at the bedside, think about the impact. So you have a patient with chest tubes, with lines in, perhaps they're on dialysis, perhaps they have fractures or traction. Let's treat their pain proactively so that we're actually able to mobilize and create a plan. So if I'm going to get my patient up who's a trauma patient, I'm going to talk to William and say, hey, my patient's reporting a behavioral pain or a numeric pain score of 6. I'm going to give them some PRN fentanyl. I'm going to talk to you, and you're going to come in time or mobility around when my pain medication is going to work. So I've given it time for actually onset and communicated my plan. So under nursing, that falls under your job too. Your job is to treat pain. Your job is to assess pain and reassess pain so that we're actually, maybe we're going to create more pain by doing mobility. So think about, anticipate what your plan A is. So my plan A is to get my patient up and dangle. Well, guess what? He passed out. What's your plan B? I got my patient up into a chair. They were able to ambulate and transfer well, but now they're not able to get back into bed. Anticipating what your needs are going to be. I have the in charge in quotations because I think leadership comes from multiple disciplines in our hospital. The person who's in charge that day, the part that I like to highlight is ensure the RN is involved in the mobility plan, coordinate a huddle at the beginning of the day. So what are our priority patients for the day? Who needs the expert services of William to come in? And recognize the barriers to early mobility. So one thing that I hear is we don't have enough slings, we don't have enough lifts, we don't have slippers, we don't have transfer belts. So let's talk about it. Let's figure out what resources do we need? What can we actually, we talked about in the earlier presentation about tools and actually the environment, the physical environment. Like, let's rearrange where the linen cart is so perhaps that patient can get up and walk to the bathroom. So knowing your plan A and your plan B. PT and OT consults is a big, I think this becomes an issue, and William, maybe you can speak to this a little bit.
So most of the time that in the old fashion, when I was a student back in the 80s, that patient need to be assessed by physio before they can start moving. To me, that nursing has the same kind of mobility assessment. They can kick starting all those assessments. Don't wait for us. So right now that we hope that we can change the activities order to be AAT when they first admitted. So the PT at our sites, we actually screen every single patient and get a game plan. Who can we see from the PT point of view, or who can nursing help to get them moving? So division of labor, once again, and collaboration, communication is the key.
Thanks, William. And the last but not least, or not least important, is the patient. So I always love when we go into our patient's room and we say, we're going to mobilize you today, and they have no idea what's going on. So we talked about the element of fear. Fear is a barrier to mobility. So when patients don't know what's going to happen, they've been feeling like crap for the last few days since they came into ICU, and we've shoved a breathing tube in and we've tied their hands to the bed. Are they going to trust us when they say we're going to get them out of bed? So share your goals. What are the patient's goals? What is the best functional activity that you can do? So what's the baseline status of that patient? And we talked about the modifiable and the non-modifiable risks in the provincial data. Chip actually talked about that. So what are some of the non-modifiable risks? Maybe this patient has deficits from a stroke. Maybe this patient is used to walking to the store every single day and has a very high functioning capacity, but being aware of that functional capacity and working towards that as a goal and returning to their quality of life. We forget about teeth, we forget about glasses, we forget about hearing aids. iPods, I love music. I play music all the time when I'm mobilizing my patients. Sometimes I don't give them a choice, so they get a little bit of country mix or whatever happens to be on my playlist. But you'd be surprised, the actual, when they sit up and the cognitive recognition of hearing something familiar, that they actually turn that mobilizing of the brain, that actually becomes very important in recognition of something that's normal and not within critical care. We're talking about tracking mobility events on eCritical. So this is kind of we've all had challenges with data in respect to mobilization. There's a provincial working group that's been started with the intentions of revising MediVision. So in the adult population, we know that the charting does not support good communication of what happened with our patients for the last 24 hours. So we're actually looking at how are we going to improve this so we can look at the assessment. So is everyone doing the same assessment for getting a patient out of bed? Are we all using the same definitions for out of bed? The pediatric group has done a lot of work in this area as well, and looking at how they're going, because they don't have anything. So if you guys think you have challenges with mobilization, they have nothing in MediVision right now to track. It's all paper. So this is something that's going to be going on, spearheaded by Melissa over the next few months in improving our charting. Here's one more patient, picture of a patient from the CV. This is the CV ICU this time. He's definitely not a pediatric patient. Action item, I will do blank when I get back to my unit to advance early mobility. Or as Dr. Dowdy said, I still remember this from my last site meeting, that you talked about ICU early rehab. It really is ICU early rehab. We're starting these patients off and giving them a best chance to return their quality of life.
I put these two quotes up. I was thinking about, am I going to get myself in trouble? But I really like it. The second one is actually always in my office in here. You guys are the one that's going to create the future. If we try to set up our goals very, very high, to me, it's not that high right now. It's achievable. We always will succeed. And I love the movie, Patch Adams. If you treat the disease, the conditions, you may win, you may lose. If you treat the patient, you always win. It's talking about the feeling and also the story behind the experience that you make a difference in here. Education is very important to all of us, but also for the public as well. It's a big shift of what people think about ICU. That is in my dream that global news can come to our hospital to see actually what the patient can do nowadays. How come our public did not know that? They expect patient in ICU, my brother, I thought the mom will be lying in bed for the next 7 days. No, we get them up. They look at me, you're crazy. I am, but still, I got an idea. If I can be crazy as a visionary, I hope that we can make a change. So, thank you.
Thank you very much for your time.